Welcome to Oncology Nursing Update, Bispecific Antibodies in the Management of Patients with Multiple Myeloma. This is medical oncologist Dr. Neil Love. For this program, I met with nurse practitioner Dr. Tiffany Richards from the MD Anderson Cancer Center in Houston, Texas. To begin, I asked her to provide an overview of the current landscape of management of multiple myeloma.
Myeloma is changing so fast. I think about where we were when I first started 20 years ago in myeloma, where we are today. It's so different, and patients are doing so much better and tolerating therapies well. So generally speaking, when patients are newly diagnosed, we're generally going to start them on a quad therapy with usually a monoclonal CD38 monoclonal antibody, along with bortezomib, lenalidomide, and dexamethasone. And, what studies are seeing is even in patients who we typically would describe as being transplant ineligible, they are able to tolerate these quad therapies just as much as somebody who's transplant eligible. And so I think we're almost moving away from this concept of like transplant eligible versus ineligible and kind of really just looking at patients as a whole and really looking at frailty. And the frailty can just may just require dose reductions. It doesn't mean that they're not eligible to receive a quad therapy, right? But adjusting the doses based on the patient that's in front of you. And I also think when we think about frailty, we have to look at why is the patient frail, right? Is it because of their disease? And then by treating the disease, we can get their disease under control and we're going to improve their performance status. And so I think there's a lot more caveats now for patients with myeloma. And just not putting them into these two subgroups, these two groups of patients.
So, just maybe to elaborate a little bit more on that, because I think, really, I think the field of myeloma has really led the way in terms of dealing with the elderly. Mm-hmm. And I think when as you say, in the past, I think myeloma was one of the first groups to even bring this up. It sort of came up in the context of would they be considered for an autologous transplant? But then as time went on, we started to get some of these newer therapies, and people started to look less so much, not just at the patient's age, although, 90, 95 can be
right.
Something to think about, but really their comorbidities, or you put it under the sort of heading of frailty, but sort of, a patient who's old and kind of feels it and looks it versus a patient who might be old in age, but really is doing very well. What are some of the things you do to try, there's some, geriatric evaluations and all, there's the eyeball test, but basically right now, what are some of the key things you look at when you're trying to figure out whether maybe a person, they may not even be that old, but whether you would consider frail?
Yeah. Really looking at their comorbid conditions, what other disease processes do they have? Do they have heart disease? And if they have heart disease, is it just like, some mild heart disease, right? Or do they have a cardiomyopathy that's with a decreased ejection fraction? Looking at, do they have diabetes? Do they have lung problems, right? Because if they have decreased lung function, then that's definitely going to exclude them from like having a transplant. And then, a lot of times what we kind of tell our patients if we're kind of on the fence about how they're going to do with like transplant versus not doing transplant is we'll say, well, let's try, a quad therapy. And if you aren't going to tolerate a quad therapy, then you're declaring yourself right there, right? Like that's definitely not somebody that's going to, do well. But I would say we're also looking at, their renal function, and because if they have decreased renal function, then we need to make sure that we're reducing those doses definitely, right? But not just basing their frailty on like, are they wheelchair bound? Because most patients with myeloma, if they have a lot of bone disease, they're going to be wheelchair bound. And so I don't usually take that into consideration if somebody's frail or not. And I think having been a nurse now for almost 30 years, I think you kind of get a sense on how you think patients are going to do, right? Like there are some patients I'll look at and I'm like, I don't have anything concrete right here to put my finger on to say like, don't think they're going to do well. But there's, I think this inherent like just taking over, just looking at them as a person and, how you think they're going to do. But usually we use their comorbid conditions, what lung problems, if they have lung problems, heart problems, things like that to make that decision.
So again, just to sort of provide an update, because we have seen data now coming out with autologous transplant, high doses of chemotherapy with patients who've already been initially treated, as you say, often with a quad regimen. Lenalidomide, bortezomib, dexamethasone has been out there quite a while, but now we have these anti-CD38 antibodies, isatuximab and daratumumab. Where do we stand nowadays? There was a big study presented a couple years ago looking at transplant. It seems like still younger patients who can tolerate that are still getting it. For the patient who's under 75 or 65 and in good condition, generally at MD Anderson, are they going for transplant? Are they being offered the option to hold off on transplant? And how do you think that compares to the rest of the country at this point?
Yeah, I would say that, if they have high risk disease, I think though that's a patient we're definitely going to send on to transplant. For those patients who are standard risk, really having that discussion, talking to them about the data, looking at, giving them 4 cycles of therapy and then looking for minimal residual disease. Because if they're negative, then that may be somebody that we could potentially defer, because we know that those patients who get are MRD negative do just as well as those patients who went to transplant and got MRD negative, right? And so that's kind of some of the nuances to that. And then having that discussion with patients, some patients are like, what? Like, if I'm MRD negative, I want to collect my cells, and then I just want to continue on and maybe avoid transplant right now, but maybe that's something that they want to revisit later. And so really I think the MRD is really kind of becoming more into play for the patients who are newly diagnosed or who are on maintenance therapy now.
And of course, MRD is minimal residual disease, where you really can find very, very, very tiny amounts of myeloma there, with, as you said, with a great prognosis. What about the choice of anti-CD38 antibody? You have isatuximab and daratumumab. I guess daratumumab at this point has the sub-Q availability, but in clinical practice, how is it determined which one of these might be used in first line?
Yeah, I mean, I would say like at our center, we generally go with daratumumab initially. Right now, that may change if we get a sub-Q formulation of isatuximab. There was a paper released recently on that. And so if that changes, I'm not sure. I don't know how we're going to go about making that decision. But generally speaking, I would say, we're using isatuximab maybe later on if a patient had daratumumab up front. But I think for the patients, their bortezomib is a sub-Q injection. And so it's just easier for patients to just get that sub-Q injection rather than having to have an IV infusion at this point.
So I'm curious, given this and sort of the way myeloma is being initially managed right now, and you mentioned high-risk patients, for example, del-17p, different characteristics of the myeloma that we know are associated with the worst prognosis. But for a patient with more standard risks, which is what we typically see, what are you kind of saying to patients about what to expect in general in terms of if they go through with this quad therapy and then let's say a transplant, or they have an MRD negative and they hold off on that, like how long it might be before they're going to need to be treated again?
Yeah. So, I think right now a lot of our docs are, because we place them on maintenance therapy afterwards, right? And I think the nice thing is with patients who are MRD negative, have a sustained MRD negative, we can actually start to have that discussion about, maybe discontinuing maintenance 3 to 5 years after they start. But patients, I mean, gosh, like we have patients who've been on maintenance therapy for so long. I mean, patients are just doing so well. And so on average, I'd say our patients are staying in remission after their induction therapy for a median of 4 to 5 years. But I mean, every day in my clinic, I have patients who've been longer. Now we're checking MRD status to see, like, having these discussions if we could potentially discontinue maintenance therapy, which I think is really nice that we're able to start having those discussions with patients, because before we weren't able to really have that discussion with them.
So today we're going to focus again on bispecific antibodies, but also we'll talk about another form of what I guess in general is thought to be immunotherapy, being CAR T therapy, which right now these therapies are being in the relapse setting. I'm not even sure, I don't remember exactly what was going on 5 years ago, but if you project a patient 5 years from now, who knows what they may have. But right now, if they've already been treated in the past and are down the road a little bit and then have a relapse, they're going to have these as options. Can you talk about, before we kind of get to bispecifics and also CAR T, some of the other therapies that are considered, for example, in the second line, in a patient maybe who's already had, a quad induction, maintenance, transplant? What are the kinds of approaches that are currently used, and then where bispecifics and CAR T start to be thought about?
So one thing is, we have our BCL2 inhibitors, venetoclax. So for patients who have a translocation 1114, we might introduce that at that point just because it's so targeted and you want patients to have the opportunity to have that drug. We also will use carfilzomib, you bringing in pomalidomide. If they relapsed on just single agent lenalidomide, then we can always bring in an anti-CD38 monoclonal antibody again, just because it wouldn't preclude them from having it because they had it with induction. But also, we do have an approval for CAR T at second line. And so that can come into that discussion as well. Depending on the patient and kind of what's going on with the patient. I would say that for most patients, we aren't necessarily doing, second line CAR T unless maybe they're high risk, or if they had a very short relapse post stem cell, right? You have the patient who maybe relapses in under 18 months. That might be a patient that we're going to say, even though they're not traditional high-risk disease, they're not acting how a standard risk patient should be acting. And so that might be somebody that we'd consider for our CAR T. And then obviously clinical trials, as we're looking at moving bispecifics up into earlier lines of therapy now. And so that's also would be an option that we would have a discussion with patients.
And I guess another thing that we'll get into at some point is, what comes first? If you have a patient who might be considered for CAR T and they might be considered for bispecifics, how do you decide what comes first? I think CAR T maybe is thought to be a little tougher on the patient, so maybe we're talking about different patient populations. But can you talk a little bit about sort of your vision of how CAR T works and what patients actually go through when they get CAR T therapy?
Yeah, so for CAR T cell therapy, we'll start with collecting the patient's T cells, and then those are sent off to the manufacturer where they utilize a viral vector to manipulate the T cells to then go after the myeloma cells. The patients will then receive leukodepleting chemotherapy because we want to make the patient's own lymphocytes be suppressed. And then we give those T cells. And I always explain to patients, like particularly if they've already had a stem cell, I say, how you got your stem cells back? It's a similar process to that. And then it's really just a waiting game and monitoring, looking for cytokine release syndrome, looking for any signs and symptoms of neurotoxicity. And so for some patients, we'll do everything in the hospital. For some patients, we can actually start it outpatient and then admit them. And then for other patients, we can potentially keep them outpatient. We have some trials where patients are being kept outpatient as long as they don't experience any cytokine release syndrome or neurotoxicity symptoms. And so that's really how the process of CAR T cell works. As far as how we go about selecting our patients, there was a study presented at ASH that really looked at patients who were over the age of, who are older versus those who are younger. And so age has really come into play for us. It's more, again, kind of looking at their comorbid conditions, how active they are. And so really looking at that individual patient rather than just saying, oh, because you're 80, you can't have a CAR T cell therapy. Because, I mean, gosh, like we see patients who are over the age of 80 who like are in better shape than some of our younger patients are, right? And so really not taking that age as like a factor and really looking at their heart function, their lung function, things like that.
Yeah, I think initially when CAR T first came out, because it's sort of a one and done type of procedure, people thought it was kind of going to have similar eligibility to autologous transplant, which involves high dose chemo. But it seems like there are a lot of patients who really were not going to be considered for an autologous transplant who might be considered for CAR T.
Yeah, definitely. I mean, I think, we've had patients where I don't think I would have considered doing a stem cell on them. But we may, do a CAR T cell product with them and they do well. They need to have the social support system. And I think that's one thing that kind of helps you to take into consideration, can this person get CAR T, or is this a person who would be better served with a bispecific? Because you need that social support, and you need to have the resources to be able to stay near a cellular therapy center. And so I think that kind of comes into play for patients.
Yeah, one of the reasons I'm starting out with CAR T is kind of seemed to come first before the bispecifics. And so we started to learn about, immunotherapy, cell-based therapy for CAR T, and then a lot of those lessons seem to apply with the bispecifics, particularly as it relates to side effects and toxicity.
Mm-hmm.
And of course, it was with CAR T that we first began in oncology in general, not just in myeloma. Of course, CAR T is used in lymphoma as well. Learn about cytokine release syndrome and ICANS, or neurologic toxicity. And then, of course, they became things to consider with bispecifics. But just getting back to CAR T, what were some of the things, or what are some of the things that are seen as it relates to what is cytokine release syndrome? Why does it happen to these patients? Can you prevent it, and how do you manage it?
Yeah. So the way I explain to patients is, we're basically, we're stimulating your own immune system. So the same things that cause you to have a fever when you get a flu or when you have an infection, we're kind of doing the same thing. We're invoking that immune response, right? And so to have a little bit of that is a good thing. Like, like we want your immune system to be a little bit stimulated. We just don't want them to be too stimulated. And so patients are monitored for that. There's a drug called tocilizumab that can counteract. It's an anti-IL-6. And so we can, give that to kind of help calm down the immune system, to help minimize how bad the cytokine release syndrome gets. And so utilizing that, and then also, if that continues, there's other drugs that we can utilize as well. But one of the biggest ways that now that we know, at least in myeloma and CAR T, is to try and reduce tumor burden. We know that those patients who have higher tumor burden tend to have the worst CRS. And so we try to, decrease the tumor burden before they go on to CAR T cell therapy. And then even with neurotoxicity, we know that those patients who have a higher tumor burden have more neurotoxicity as well. And so they're monitored. And then we obviously are going to be checking their neurological status twice a day. Or if they're doing it outpatient, teaching the family member how to do that, what questions to ask and when to ask those questions. And then also letting the caregivers know that they may notice subtle changes that, the nursing team might not even pick up on, right? Because they know their family member so well. And to let the team know if you start to notice some subtle changes, because that's also really important.
And when do you typically see, at least with CAR T, cytokine release, and when do you see neurologic issues? And can you talk a little bit more about the types of neurologic problems you see?
Yeah, so patients can get confusion. We ask them a series of questions to say where they are, what year it is, what month it is, what hospital they're at. We have them count backwards from 100 by 10. I remember initially they did it by 7. I was like, oh my gosh, like I think I would have a hard time with that. I'd really have to be thinking about that. So now it's by 10, which makes a lot more sense. And so we ask them those questions. And then also, they can, worst case scenario, if we're going into a grade 4, they can get, grade 3, grade 4, they can get cerebral edema. Generally, we don't see it that severe in myeloma. But they can get this altered mental status where they're only oriented times 1 or 2. They're not able to write a sentence anymore. And so those are really going to be the clues that we're looking at for neurotoxicity. So those are kind of the acute. With cilta-cel, we can see a late onset neurotoxicity where we can see some movement disorders. We can see facial palsies. And so patients need to be aware of that when they're getting that product.
So, taking those things sort of as a little bit of back, I guess the other thing about CAR T is like transplant, it's generally done just once. And then if the patient has a great response, which a lot of patients will, the patient's not going to be on any therapy for a while. And a lot of these people have already had a lot of therapies. So anything you want to say about the sort of one and done thing about CAR T and how patients respond to being off all therapy?
It's really amazing to see. Like, never would I have thought that somebody who's had so many lines of therapy, 8, 9, 10 lines of therapy would be able to be off therapy. And that's like an incredible gift for patients, right? Because they've been on chronic therapy for such a long time. And so to see patients like getting back to like, feeling good and having a lot of energy and getting back to this great, quality of life again is really amazing. And so I think it's really been such a gift for patients. But also to see like these remission durations for patients who are penta-refractory. We used to say that patients who are penta-refractory, their median survival was like less than 6 months. And now they're getting, they can get a CAR T cell product and, it can last 1, 2, 3 years, right? And so it's really been amazing to see. And I'm always make sure that patients understand that while the CAR T cell product is one and done, that there's other things that they still have to take. They have to, be on their PJP prophylaxis and their IVIG and things like that. I once had a patient be like, I thought this was one and done. Why do I still have to do this other stuff? And I'm like, well, that part was one and done, but we have to do these other things to make sure you stay healthy.
So any reason to think, lymphoma, particularly diffuse large B cell, but even beyond that, we see prolonged complete responses. People are thinking maybe these, we need more follow-up, and maybe some of these people are cured, as happens with, for example, diffuse large B cell. What about in myeloma? I think there was a hope that was going to happen. It kind of seems like with time, we're seeing eventually a lot of these people, or maybe most of them, are having progression.
Yeah, they are. But I think it'll be interesting, I think, to see like what you said in the next 5 years, what happens as we're moving, CAR T sooner and earlier lines of therapy to see, if maybe that is going to be, maybe we'll get closer to a cure. But yeah, unfortunately, patients are, relapsing after CAR T. And so that's the one, I think the disappointment for a lot of us is I think there was a lot of hope that maybe this would be the thing that would get us to a cure. But I think you really won't know that until you get into the first line setting.
So I think you've painted a great picture of kind of what's involved with CAR T therapy. It sounds like if someone were eligible for that, it'd be very, interesting to consider. But also we have this option, maybe a little bit less difficult for the patient, of a bispecific antibody. And there are patients who are considered eligible for both CAR T and bispecifics. A lot of them might get CAR T first and bispecific second, or they might not be eligible for our CAR T and go right to bispecifics. Would you say in general it's, sort of a less difficult course through bispecific than CAR T?
I do. I don't, they don't get, you don't really see a lot of the neurotoxicity with bispecifics. And if they do get CRS, it's generally grade 1. You might get a grade 2, but generally the severity of the CRS is much less with bispecifics compared to with CAR T.
So I'm curious how you think through the mechanism of how bispecifics work, what they are, how you explain it to patients. I just saw a cute little cartoon. I don't know if you know Dr. Lunning, Matt Lunning from lymphoma fame, but I saw a cartoon he did of Lady and the Tramp, sharing spaghetti as an
Oh, wow.
way. I know you like those kind of analogies of how a bispecific works, but what's your vision and how you try to explain to a patient sort of what bispecific is and why it's different than CAR T?
Yeah. So when I explain biospecifics to patients, I explain to them that, on the surface of your cells, you have these receptors that help to differentiate the cells from one another. And how this drug works is it's going to bind to this receptor on the surface of there's a receptor on the myeloma cell, and there's a receptor on the T cell. And that it will bind to the receptor of the T cell, and it binds to the receptor on the myeloma cell, and it causes the T cells then to, go after the myeloma cells. And I think because like most patients have already had a monoclonal antibody, like they kind of understand that. And I always explain, because for some patients, they want to do CAR T right away, or like they're CAR T, CAR T, CAR T, but it may be that their disease is not at a place to get them through to CAR T, right? So that we need to kind of think about doing a bispecific now. And so I say, it's kind of a similar process, not exactly, but you're still utilizing those T cells to engage with the myeloma cells and to go after the myeloma cells. And so then they're like, oh, okay. Like, they kind of understand that a little bit better. But I think it is hard because I think a lot of patients are just like, I got to get to CAR T. I got to get to CAR T. Right. And it's like, but if your disease has an aggressive relapse, you have to be off therapy before you get the CAR T. And then you have to be off therapy, like before you actually get the infusion. And then there's the question of, well, will you have enough T cells to even make the CAR T cell product? That we actually are going through that right now with a patient he's undergone 2 collections now for CAR T, and he's still not quite yet to having enough cells to go to get the infusion yet. And so we're going to try a 3rd time collecting. And so you run into that problem too. And so for some patients, the bispecific is a nice option.
And not to mention, you see some pretty good responses with bispecifics. I'm not sure how it's going to really play out in the long run because some of these patients seem to do as well as with CAR T. We'll kind of get into that more maybe with your patients. What about the risk of infection? You mentioned that even though patients maybe finish the CAR T, they might have to get other therapies, and in some cases preventing, and in other cases they actually develop infections. What kind of prevention maneuvers need to be thought about with bispecifics? And is that the same as roughly as with CAR T? What do you do about vaccination, IVIG? Can you kind of compare again bispecifics and CAR T?
Yeah. So regardless if you're doing CAR T or bispecifics, you're going to be on IVIG, and particularly if your IgG level is less than 400. But in those patients who are an IgG myeloma, I always tell, nurses and nurse practitioners and PAs that you really need to look at the IgG subclass levels, because if somebody has an M protein of like 1.2 and their, IgG level is 1200, most of that IgG is not going to be actually functional IgG, right? It's all because of the myeloma. And so not to just go by the IgG level. And that's a little bit of a difference between myeloma and lymphomas. They don't necessarily have to worry about that piece. But you're going to be on prophylaxis, like shingles prophylaxis, and then PJP prophylaxis. So for CAR T, you're going to be on it for PJP prophylaxis for at least a year. For bispecifics, you stay on it till 6 months post your last dose of bispecifics. And, for myeloma patients, they start off already at a high risk of infection, right? We know that the number one cause of death in myeloma patients is infection. And so we have to be really cautious and make sure that patients are aware of that risk. For CAR T, we generally are now revaccinating patients similar to what we would do after stem cell transplant. And so giving them all their baby shots again. And then making sure they're getting their RSV and, their shingles vaccine as well, and their flu shot. And so those are some of the strategies that we're utilizing. And then obviously if they get neutropenic, to add on some prophylactic antibiotics if they're having a prolonged neutropenia.
So I want to get into some of your cases and get a little more granularity about what people with bispecifics go through. But first, seems like every part of oncology, when you see a new type of therapy, is not just one drug. There's 3 or 4, In breast cancer, you have 3 CDK inhibitors and 3 oral SERDs. And, a lot of times these are not compared directly. And so we end up with several approved agents or about to be improved agents, and people are trying to figure out which one is better. Of course, it's better to have any one of these better than not anything, but then you want to get the best type of drug or specific drug. How do you view the available bispecifics right now when you compare them? Some of them work differently. They have different, some are sub-Q. Can you kind of provide sort of a broad overview of the different types of bispecifics for lymphoma, for myeloma that are currently available? And then how, if you have a choice, you theoretically would make that choice?
Yeah, so we have 2 different classes. So one that targets BCMA or B cell maturation antigen, or that targets GPRC5D. And so if I have a patient who I think could be a CAR T cell candidate in the future, then I would typically avoid, maybe not choose a BCMA bispecific, because that's the same receptor that CAR T cell is targeting. And instead, I may go with talquetamab that targets GPRC5D. And so that's one, that's going to be the first differentiation. If I don't think that a patient is going to be a candidate for CAR T, then I would be looking at one of the BCMA, either teclistamab or elranatamab. And I think a lot of places, they may have one on formulary versus the other. And so, unfortunately, like you said, we haven't had a head-to-head between, teclistamab and elranatamab to really tell us which one is better. With elranatamab, it is a shorter hospitalization. And so that can play a role into it, because you're trying to minimize the time that the patient has to be admitted to the hospital. But, as we're starting to look at, there's centers that are now moving to all outpatient dosing of their bispecifics. We're trying to move to that at MD Anderson, but haven't quite got there yet. But if a center has the infrastructure for that, I'm not sure exactly how, other centers are deciding, but we will generally go with either teclistamab or elranatamab. And there's a little bit more of a tendency to go towards elranatamab just because of the shorter hospitalization stay for patients.
And I know there are other agents that maybe aren't approved, but there's been a lot of research done on them. One is linvoseltamab. I don't know if you're aware of any others or you have any experience with linvo. Again, how does that differ, and is that likely to become available?
Yeah, so linvo targets BCMA as well. That's given IV, although it's a less frequent dosing. You can very quickly de-escalate to a monthly dose with linvo. I know that I think there's studies that are looking at sub-Q administration of linvo. So, hopefully, if it gets approved, it'll be a sub-Q administration just because that's so much easier for patients than have to get IV. And with the linvo, it's once a week dosing. So even if patients are admitted, they're admitted for day one, they're observed for 24 hours, they can be, discharged, and then they come back in for day 8. So again, it's a less admission, and they actually don't even have to be fully admitted. They could be admitted, observation. And so that's one distinguishing feature compared to the other BCMA targeted therapies. And then there's simvastatinib, which hasn't been approved, and that targets has a different target to it that's currently undergoing investigation as well.
So let's take a look at some of your patients, starting out with this 80-year-old lady on teclistamab. I got to tell you, one of my favorite stories in oncology in general is about a man that I did a video interview. I don't know if I ever told you this. I did a video interview of this man who was on teclistamab, and he'd been the time that I interviewed him, he'd been on it for a year and a half.
Wow.
Had very little tolerability issues, in a great remission. He was out, living his life, doing great. And the day that I interviewed him was the day it was approved.
Oh, wow. That's awesome.
So, he had a year and a half jump on everybody else because he participated in clinical trial. And I like to use him in general in oncology as an example of why being in a trial can be helpful, because all these drugs that we're talking about today initially were given to people on trial when they weren't approved. And you see a whole bunch of people had these great responses before the drug was even approved.
Yeah.
And he was one of them. But what happened with this 80-year-old lady? What kind of shape was she in, incidentally?
Yeah, she was in good shape. She had really a difficult time tolerating therapy. We're having to do a lot of dose reductions, holding therapy. She had a lot of fatigue and diarrhea, and we weren't able to really get to a place where we were able to keep her on therapy. She developed a lung fibrosis from carfilzomib during her induction therapy. And then at relapse, we tried re-challenging her and she got short of breath again. And so we started having the discussion of CAR T versus bispecific. And it was several months of having this conversation with her. And she was very apprehensive. She was having a difficult time trying to make a decision. And we were worried about her with CAR T. We just, she's 80, and while she's fully ambulatory, she's tiny. And so we just had some concerns. And so we elected to, kind of say, let's do the bispecific, and, kind of go from there. So she had a fantastic response. I mean, after one cycle, her light chains went straight down. I mean, it was just amazing. She had grade 1 CRS. Eventually, she did achieve she's currently in an unconfirmed complete response, and is doing well. Now, a few months ago, she developed some increased confusion. Now, she had some at baseline, and she had some neurocognitive testing about a year ago. And so we were concerned about this confusion she was having. So we did get an MRI of the brain, which, didn't really show anything. And her neurocognitive testing was largely unchanged in the last year. And so we held therapy and just to give her a break, and she's doing great. And so she was so worried. She's like, I don't know, do I need to be on therapy? And I was like, look, you've had like 10 cycles of therapy. You're doing well. Your numbers are low. Let's just kind of keep you off therapy and watch your numbers. And so now she's off therapy and she's getting her energy back. And she's doing like remarkably well. And so, just amazing, and here was somebody who wasn't able to tolerate all of our approved therapies and we give her a bispecific and she did great with it. And she's 80. And so, just because somebody didn't tolerate the, other therapies doesn't mean that they're not going to tolerate bispecifics, because they may actually tolerate it better. There's no steroids involved except for that with that first cycle. And yeah, she's done great.
So it also ties into the issue of how long they receive the bispecifics. It's interesting in lymphoma, some of the bispecifics, they stop. Others, they continue indefinitely. As you mentioned, a couple or several approved and others that are being looked at and are encouraging. Are all the bispecifics in myeloma given until progression or toxicity, or do some have a finite duration?
Yeah. So right now, I mean, on all the studies, they were done like indefinitely. I think, there's been some studies that like now, I think with like, at least with teclistamab, we can de-escalate to at least every other week. And we know that patients continue to do well. I think over time, like, I think, as more studies are being done, I'm hopeful that maybe we'll start to look at that, because if we don't need to keep hitting them, the myeloma, and we can give patients treatment breaks, and allow some of their immune system to recover, I think, in the long run, they're going to do better. And so I'm hopeful that we'll get those answers to those questions.
So you mentioned that this woman actually had grade 1 cytokine release syndrome. Can you talk about exactly what happened to her, when it happened to her, and how grade 1 compares to higher grades?
Yeah, so she developed on day 2. So she got her dose, her first step up dose. That was on day 1, and the next day she developed a fever. And so that's what we generally consider grade 1. She didn't require oxygen. Her blood pressure was fine. And so I think for her, given her age, they gave her a dose of tocilizumab, so that, and she didn't have any fevers after that point. I know some centers are doing prophylactic tocilizumab, and there's some data coming out as far as like giving that ahead of time to help mitigate the CRS from even occurring. But at our center, we haven't done that yet. But hopefully, if we can get some FDA approvals with tocilizumab as prophylaxis, then we could probably actually move even more patients to doing outpatient bispecifics.
So just to clarify another thing, which is that you mentioned in terms of this issue of a patient who may or may not be eligible for CAR T, and sort of where bispecifics come in, and that maybe somebody might get even bispecifics before CAR T if they have a lot of tumor.
Mm-hmm.
What about bispecifics after CAR T? Is that ever done? Is it effective? Do you usually switch the target from BCMA to, GPR? I always
Yeah.
forget the letters.
I know, it's a lot. It's a mouthful. It really depends on how long it's been. Generally, if they had a CAR T and then they relapsed, we would do the GPRC5D, that target, and then maybe later on go back to a BCMA bispecific, just because we know that those, just to allow that upregulation of BCMA again, right? The longer you can get away from a drug that targeted BCMA, the better the patients are going to do. So generally, we would do talquetamab after CAR T. But then if they progress on talquetamab, we may consider, a BCMA bispecific at that point.
So actually, let me go before we get into talquetamab. Let's stay on BCMA for a moment and hear about your 73-year-old patient, a 73-year-old man who got linvoseltamab, I guess, on a clinical trial since it's not approved. What happened with this patient?
Yeah, so he had standard risk disease. He received induction therapy, and then went on to an autologous stem cell transplant and was placed on maintenance with lenalidomide. So he progressed within 6 months of starting maintenance. So, which was rather, again, like even though he was standard risk, that early relapse after stem cell kind of tells us that maybe this is actually a more aggressive myeloma. So we had a clinical trial where patients were placed on daratumumab, bortezomib, dexamethasone for 4 months, and then they switched to daratumumab, ixazomib, dexamethasone. However, he progressed within 3 to 4 months on the trial. And so he was placed on daratumumab, pomalidomide, and dexamethasone. He progressed, I think it was about 6 to 7 months. And at that time, he had extramedullary disease with a liver mass as well as lymphadenopathy. So he went on a clinical trial with linvoseltamab. He had a great response. He had complete resolution of his extramedullary disease. His blood and urine, he was in a VGPR, and he remained on therapy for 18 months, which is really remarkable for a patient with extramedullary disease. I mean, historically, when patients had extramedullary disease, their median survival is like 3 to 6 months. So here is this guy, he's got a liver mass and lymphadenopathy from his myeloma, was on therapy for 18 months. I mean, it was like amazing. And at that time, he did have recurrence of his extramedullary disease. And so we're trying to, he's currently, we're trying to get him into a trial with GPRC5D. He actually underwent collection of his T cells. However, he was admitted to the hospital with shortness of breath, and he actually has a cardiomyopathy, possibly from carfilzomib that he was receiving as bridging therapy versus heart disease. But I mean, 18 months with extramedullary disease. I mean, previously that was unheard of.
I can't remember many cases I've heard where people with myeloma had liver disease, not even nodes. I don't think I've heard that much about. So amazing that he actually had a great response given that. Also, really interesting, the trial that he's on. This is a different type of CAR T than's currently out there. The two CAR Ts are BCMA directed. This one has the same target as talquetamab that we're going to talk about, the GPRC5D that I can never pronounce. I'm curious, how did he do when he first got the linvoseltamab in terms of cytokine release or neurologic issues?
Yeah, he actually did really well. He didn't have any neurotoxicity. He did develop like grade 1 CRS, I think with his second dose, not with his first dose. But he actually did really well. It was grade 1. And I think he didn't even require tocilizumab. He did really, really well with it.
So I guess another thing I was going to ask you about in general, in oncology, we always move things up. And I know in our lymphoma programs, they're talking about moving bispecific into first line. You have very effective, just similar story to myeloma, very effective therapy, relatively low toxicity. So of course, everybody wants to move things up. And now they're looking at that first line in lymphoma. What about trials of bispecifics in myeloma, bringing them in first line? Have you had any trials like that at MD Anderson?
Yeah, so we actually have a trial right now for upfront with, I think, with Limbo. And then also, using it at first relapse, usually looking, I think our first relapse ones, early relapses, a combination of teclistamab and talquetamab, so doing a dual target. And so, I think there's just a lot of excitement with these new, immune therapies. Like, it's incredible.
Well, let's talk about the other bispecific out there that has a different target and different toxicity. A lot, pretty interesting. Your story with the BCMA bispecifics is kind of, I'm not going to say simple, but once you know CAR T, it's kind of familiar. But now we get into these other targets, as with talquetamab, it's a little bit of a different story. So actually, before you even tell us about the 6-year-old woman, can you talk a little bit broadly about talquetamab, why it's different than, for example, teclistamab or the other BCMA bispecifics? And broadly, what are the kinds of tolerability issues you have with these other types?
Yeah, so talquetamab targets GPRC5D, and I think one thing that's a little bit different about GPRC5D as opposed to BCMA. So BCMA is predominantly only expressed on plasma cells. GPR5C5 GPRC5D is expressed on skin cells. It is expressed in hair follicles. It is expressed in the cells, that affect taste. And so, when patients, it's also on the nails. And so when patients get talquetamab, they can have all these other side effects that you need to be aware of and be very quick to manage. Because obviously, if somebody's not able to taste their food well, they're going to start to lose weight, and then that can lead to its own set of problems. And so that is one thing that's a little bit different with talquetamab as opposed to the BCMA bispecifics.
And well, let's see, sort of get a little taste of how this plays out in practice and hear about this 60-year-old woman. What happened with her?
Yeah, so she was diagnosed back in 2011 with standard risk of therapy. She basically had gone through like almost all the myeloma therapies. She had extensive disease burden when she got teclistamab and didn't respond to therapy. She actually had to get nephrostomy tubes because she was having hydronephrosis due to the extramedullary disease. So we had this conversation with her about her goals of care. And so, she said, my goal is to see my first grandchild born. And so then we were like, well, when is when is the baby supposed to come? So I think this was like in spring. She's like November. And we're like, okay. Wow. Okay. Well, we're going to do our best. And so, we actually were able to get her through. She was on selinexor and Dexa. And so talquetamab gets approved. And she was one of the first patients to go on that. And she started like right around the time that the baby was due. And excellent response. Her PET scan she had a complete metabolic response to therapy. She got into a complete remission, was amazing. So we actually have a management guideline for talquetamab that we developed based on things that Mount Sinai has presented about their experience with talquetamab. And so she actually did really well with talquetamab, which was really amazing. Every time she came in, I'm like, are you sure you're not having any problems? She's like, no, I'm fine. And I'm like, are you sure? Because I was like, I don't really understand what's going on here. But it was amazing. She got to see her grandbaby celebrate her first birthday. Like, not only did she get to see the baby born, but like she got to have another milestone. And it was just like, this is like my favorite patient story because like, I think like this is why we do what we do in oncology. Like,
Absolutely.
This is the reason. This is why we do what we do.
100%. Another thing I noticed here about this case, and I think this is kind of maybe where things are right now, is that after she got her second cycle, she was, quote, handed off back to her community oncologist. And
Yes.
you were mentioning a lot of these patients have to go in the hospital nowadays, and that maybe we're going to be moving more towards outpatient. They usually are getting started by a center of excellence like yourself, but people are thinking, well, maybe in a community-based setting, they're going to be able to start using these drugs without it. Where do you see things heading in terms of sort of the interface between the community-based general medical oncology setting and the myeloma specialty setting in terms of bispecifics? And what would you say, or what did you say to the community-based nursing staff when they were about to take over? I know you did this great paper on like transitions in myeloma. What were some of the things that you wanted to make sure they knew about as they picked the patient up for cycle 3?
Yeah, so we touched bases with the practice prior to admitting her for the talquetamab so that they could start getting their processes in place, get their REMS program going and things like that. And then prior to, the patient going back to their local oncologist, picking up the phone and calling and having a conversation, I think I talked to the nurse practitioner at the time and had a in-depth conversation, said this is the treatment course. They develop, cytokine release. This is when she is due for her pentamidine. This is when she's due for IVIG. This is what her counts are doing. And making sure that you give that handoff. I kind of equate it when I talk to nurses of like, when you give a shift report, this is what we need to be doing with these patients. We need to give a report directly so that the team that's receiving the patient has the opportunity to ask any questions that they may have, and that everybody is on the same page, so that the patient isn't put in the middle of having to communicate something to the local team. And so I think it's really, really important. And then we also give them, the last clinic note so that they also have something in writing to take with them. And that handoff is so crucial when you're talking about coordinating a patient's care. And I think as bispecifics are going more into the community practices, that's going to be essential for patients to make sure that collaboration is there.
Of course, you have the same issue with CAR T therapy, that they get treated by tertiary center and then they come back to maybe a community-based setting. I thought this paper, optimizing transitions of care in myeloma, multiple myeloma, immunotherapy, nursing roles, was really interesting. You have all these forms in there that I guess you utilize in this situation. Is this something that's in general getting more attention in oncology in general, or specific to myeloma? I think it's so important. It happens so much in oncology in general, not just myeloma.
Yeah, I mean, I think I don't know if other, tumor types are better at that collaboration. I think in myeloma, we have to get there because our patients are depending on it. Our patients are living longer. Our patients are older. And I think when you have an older population, like you can't rely on the patient to be that communicator, right? Like, somebody who's 80 years old and, they've got, all these other things that are going on for them. And so I think in oncology, we need to get better at doing this, collaboration and this handing off to patients. And as these therapies are going more into community, it's going to benefit the community practice providers if they have somebody that they can pick up the phone and call, right? Like, I mean, I'm happy to troubleshoot anything with a local, nurse or nurse practitioner or PA, even if it's not my patient. I may not be able to give them advice about the patient, but I can help them to like kind of, think about processes and stuff. And so, and especially when we think about rural America, right? Like, I mean, that's just its own, set of problems, especially when you're thinking about, there might not be an oncologist there all the time, right? They kind of go in and they're rotating in and out and things like that. And so to have that collaboration is just so, so important.
Yeah, I was really struck by that paper. In fact, I think we're going to talk some about that at ONS in general, because it really makes so much sense to me. I was just flashed, I don't know if you know, but now it's a different kind of bispecific, but it is similar, and it causes CRS and all, approved in small cell of the lung.
Right.
Like they have no background with bispecifics at all there. So these kinds of transitions for, patients are going to start to cross, sort of tumor lines, so to speak, as therapies go. We have TDXD in breast cancer, and now it's being used in all different kinds of tumors. And the docs, a lot of times, they don't know anything about it. They've been isolated from it. So it's all hands on deck.
Yeah.
Maybe we can finish out with one more case. So you've got a 74-year-old man also who got a bispecific, another patient who got teclistamab. I imagine right now teclistamab is the one that the most patients have gotten. Does that sound right?
Yeah, I think because it's been around the longest,
Right.
And at least at our center, like, we had teclistamab, and then we were focused on getting talquetamab up and going. And so like elranatamab kind of took a back seat there for a while. just because we already had teclistamab on board. So this guy has had myeloma since 2006, had, got a CR after transplant and was actually an observation because back then weren't doing maintenance. Was on a clinical trial with a drug called Array 520. And then relapsed. He's had a total of 15 lines of therapy.
Wow.
Yeah, he's had AFib. He has a cardiomyopathy, CHF. So we had talked about CAR T versus bispecific. Just because of his history of LGL, we had concerns about CAR T, given that with cilta-cel, there's been some reports of secondary leukemias. And so we placed him on teclistamab. Again, excellent response. But what's really amazing is his platelets have always been in the 30s to 40s. They maybe get up into the high 50s. Doing great on teclistamab. His platelets are staying in the 30 range, but he hasn't had like worsening of his thrombocytopenia even on this drug. And so I think this is just highlights how like you can have patients who are cytopenic but can still tolerate bispecifics.
What is really great case. So that maybe is a good introduction to one other thing I was going to ask you about. You kind of alluded to a little bit. We've had in the past in myeloma the issue about lenalidomide in second cancers. That really hasn't stopped anybody from using lenalidomide because the benefit's so great. But then myeloma patients get so many different therapies, you can understand why they might have a higher risk of a second cancer, leukemia, even from the related to the myeloma. But then we saw, at least with the CAR T, a report of second cancers that were T-cell lymphomas, which are pretty unusual. A few of them they're thought maybe be related to the CAR T. So I was curious right now, it seems like the benefit from CAR T is so much greater than the small potential risk. What you say to patients nowadays about second cancers, and also whether you see increased second cancers with bispecifics. I'm not sure if there's enough time to really evaluate that, but any signals with bispecifics?
Yeah, so far with bispecifics, we haven't seen a signal towards that yet. But again, you never know what's going to play out a few years from now. With CAR T, I think it's all about I think every patient has different level of risks that they're willing to take, right? Some patients are very risk averse and other patients aren't, right? And I think it's all about disclosing that risk, right? And giving them the data, letting them know okay, this is what they saw, and so I think it's really what's going to play out, I think, is as, the phase 3 study with the first and second relapse CAR T cell studies. And then as CAR T cells being moved to the upfront setting, I think that's really going to give us a better idea of are these secondary cancers that they saw in the, refractory setting, is it due to CAR T, or was it just because, like you said, they've had all these prior therapies and, their immune system just is not that good anymore, right? And there's no immune surveillance. And so I think time will tell. I think probably in the next 4 to 5 years that we'll have a better understanding. But I think for right now, it's just about letting patients know. I've had some patients that are just like, I'm not worried about it, right? But then you have other patients like, I don't know, between that and, the risk of having a movement disorder and, those risks, they don't want to take that, right? And so I think it just really depends on your patient, how risk averse they are.
So final question, anything that you want to add to what we've talked about today about bispecifics, something maybe we didn't cover or anything you want to emphasize? Any other comments?
I would just say that, patients that you think that maybe they won't tolerate it, don't rule them out. And I would also say, get them to a cellular therapy center early. we try to, like we generally will send our patients back to the community oncologist to get their treatment and things like that, and partnering with the community oncologist. But the earlier we see them, that, particularly if you're thinking about CAR T, it's so much easier when the patient is not hasn't gone through all of their lines of therapy and now they don't have anything left, and now you're sending them to us for CAR T. It's a lot easier, and we can do it in a much safer, controlled way if we see those patients early. So I would just say early referral for CAR T bispecific is really, really important.
This concludes our program. Special thanks to Dr. Richards, and thank you for listening. This is Dr. Neil Love for Oncology Nursing Update.